Hi, I'm Dr. Nitin Sauber from Mumbai, India, and today I'll be talking on ultrasound interventions in non-obstetric practice. This lecture is basically meant for people who are just about to start doing interventions or for postgraduate students, and I hope it's going to be useful to you. Thank you. Now, when we choose an imaging modality for intervention, it all depends upon the lesion itself, its location, size, relative visibility, availability of imaging modality, and the personal experience. But by far and large, any lesion that is well visualized on a sonogram is amenable to ultrasound guided intervention. Ultrasound has several strengths. It's the only real-time technology and therefore it is safe. It's got speed because you are seeing things real-time. As soon as the needle comes out, one can compress the site of puncture, and if there are any complications, they can be picked up very easily. Here, for example, we are aspirating a breast cyst, and before the patient knows about it, the fluid is out. Real time is the biggest advantage of ultrasound in interventions, and here you can see that we are doing an FNA from a lymph node which is very close to the carotid and the jugular vein. But since we are able to see the tip of the needle through and through during the procedure, we can be sure that it does not touch the carotid artery or the jugular vein. This is another example where real-time technology comes into play. This child has an empyema very close to the pericardium, and as you can see, the needle is entering into the pleural cavity, but because of the real-time technology, we can be sure that the needle is not touching the pericardium or any unwanted area. Besides this, ultrasound has several strengths. One can guide in multiple planes. One can switch on color Doppler and have a look at the vessels around. It's readily available, and one can do procedures as with a portable machine in the ICU as well. So there are two types of interventions: diagnostic, which includes FNAC and core biopsy, and therapeutic, which are mainly drainage procedures, ablations, radiotherapy, etc. We will just go through some of those which are done routinely. Now it's very important that we do the procedures in a proper procedure room which has got basic facilities with all the needed instruments and basic patient monitoring devices as well as basic resuscitation equipment as well. Pre-procedure, it is very important to take consents as per the requirements of each country. It is also important to look for altered coagulation, especially if you are doing a core biopsy of a vascular organ like a kidney or the liver. Prophylactic antibiotics may be given, especially in a prostate biopsy. Pre-medications usually are not needed, but it is better to keep an IV line and keep atropine, Fulsed or glycopyrrolate ready at hand, especially when you are doing a pleural tap. Looking out for coagulation disorders also depends upon the standard of care in your own setup. So we have various guidelines which have come from various institutes. One can adapt a guideline. For example, we have guidelines from the University of Wisconsin which are good. But as I said, that each place can have its own guidelines. But when we are doing a core biopsy of an organ like liver or kidney, it is better to check for coagulation disorder. Similarly, stopping anticoagulants like aspirin, clopid, etc. would largely depend upon the institute where you practice and the guidelines which are available at your place. It's very important to take complete aseptic precautions, clean the probe properly as per the guidelines of your manufacturer. All the accessories like the guides, guns, etc. have also to be properly sterilized as per the requirements of the manufacturer. Even when we prepare the patient, it is better to prepare the patient with clean the patient properly with iodine or betadine, and also drape the part so that we do not touch any area which is unsterile. There are two types of ultrasound guided procedures. One is a freehand approach where the needle is free in our hand. This allows greater flexibility and also allows subtle adjustment when we do the procedure. We also have guides, and typically guides are used for transvaginal or endorectal probes. Guides can also be used when you are negotiating through a very small area. Here, for example, in the abdomen, the window is very small, so if I don't want to make any mistake, I can use a guide on my probe. When we start doing procedures, one of the most common problems which people encounter is the non-visualization of the needle tip. And the commonest reason why the needle tip is not visualized is because of improper alignment of the needle tip and the transducer. So we have to remember that the needle and the central ultrasound beam must be in the same plane. The lesion and the needle should be in the same plane for visualization of the needle in the lesion, as we can see in this figure. There are two types of approaches, in plane and out of plane. When we do an in plane approach, the needle goes within the beam from a distance away from the probe. So that's the needle being placed, and as we insert the needle, it will go within the beam of the ultrasound. If you want to see how the needle goes when you do an in plane, we can put a needle in attachment of the probe for biopsy and then just push the needle. As we can see, the needle is going now within the plane of the ultrasound. When we do an in plane approach, the needle is visualized during its entire path. Of course, we have to traverse a larger tissue, but this is an easier technique for someone who is new. We have out of plane, where we place the needle adjacent to the probe and then insert the needle. In this procedure, the needle is not visualized along its entire length. Of course, a less tissue is gone through. Here, for example, we are doing an FNA out of plane, and here we are doing a pleural tap out of plane. Sometimes, when the area where you are working is very small, we might have to go out of plane. So here we have two examples of an FNA being done on lymph nodes. This is an in-plane example where we can see the needle through and through, and this is out of plane where we can see only the tip of the needle. It's very important to see the needle through and through, right from the point you enter the skin till you reach your target. And there are several tips which can be useful to improve needle visualization. First of all, there should be a proper position of needle insertion. The needle should be parallel to the long axis of the transducer and should not be out of axis. One should work with shallow angles of the needle, and rotation of the bevel towards the transducer and smooth motions can also improve needle visualization. Here is an example where we take advantage of the air in the bevel to look at the tip of the needle. We can also improve the needle visualization by doing a jiggling movement as we go through. We can improve the reflectivity of the needle by special codes. We can use chrome on your ultrasound machine, or we can also use color Doppler where we can see the tip of the needle as a colored artifact. Here's an example of an eco-coat needle. This needle is visualized better, but these are costly needles and we don't use them in day-to-day practice. Here's an example. If everything goes fine and your technique is fine, you can see the needle through and through after you have entered the skin till you reach your target. Let's talk about FNAs, which are most commonly done. We have a choice of needle starting from 18 gauge to 24 gauge. These needles could be small or they could be large in length, as for example here we have spinal needles which are longer in length. It all depends upon the depth at which you are working. For an FNA, the finer the needle, the better is the yield for the cytologist. So one should use as fine needles as possible. This is very important. So there are two types of FNA techniques. One is a capillary filling and the second is with the use of a syringe where we apply a slow suction. Capillary filling is typically used when you have a very vascular organ, like for example thyroid, or sometimes when you have a breast lesion which is very vascular. What we do here is just insert a needle without the syringe and then do a shearing motion, rotate the hub and then take the needle out of the lesion. We can also do an FNA with syringe where we put a 5 or 10 cc syringe and then apply a slow suction. And then also move the needle with rotation as we do that. It is very important to discontinue the suction while withdrawing the needle. It is very important to biopsy from the right area. Generally, the yield is more from the periphery of the lesion because very often the center of the lesion is necrotic. And we have a partially cystic and a solid lesion. It is important to hit the solid area first. Remove the needle and then if required, take the fluid from the cystic area. After you get the tissue, it is very important to take proper care of this tissue. There are two aspects. One is making the smear and second is fixing the slides. So when we make the smear, we put one slide over the other and gently pass it over this so that we get a thin film of the tissue or the fluid which we have aspirated. The fixing can be done with a fixing solution or one can just do an air dry, but it is important to label the slides as you have fixed them. So if you have fixed them with a solution, you have to label it saying that this is fixed with solution. If you have kept air dry slides, you have to label them separately. This is important for the pathologist. We also have automated spring-loaded biopsy guns for trucut biopsy. They are available in various sizes as well as different manufacturers have different types of techniques. This has several advantages. We get a larger core of tissue consistently. Most often a single pass is enough. One can fire it with one hand and there is actually no increased risk of complications. These are newer guns where you can actually adjust the throw of your biopsy core, either say 15 millimeters or 22 millimeters, depending upon where you are taking the sample. When you do a core biopsy with an automated gun, remember that the needle is going to go at least 2 centimeters from where you fire it. So you have to make sure that there is no important structure beyond 2 centimeters of the point where you fire the needle. This is very important to remember. If you want to have multiple cores, then it is better to use a coaxial system where we have an outer core needle which is very smooth and sharp, which goes within the lesion, and then through that we pass a cutting needle. When we do a thyroid FNA, different societies have come out with different guidelines, but generally we have to make about 10 to 20 to and fro movements every time. We have to have 3 to 6 passes depending upon the size of the lesion, and after withdrawing the needle it is better to apply a gentle pressure and then of course make slides out of it. And as I said earlier, if you have a cystic nodule with a solid component, hit the solid component area 2 or 3 times and then aspirate the fluid in a separate syringe. Here's an example of a thyroid FNA being done. That's a solid hypoechoic lesion in the thyroid, and we are doing multiple to and fro process. As I said, at least 10 to 20 to and fro movements. That's a carotid artery which is adjacent to that. In thyroid, FNA is good enough, but if the yield from FNA is not adequate, and most important, as in this case, if you are suspecting a lymphoma, then it is better to do a trucut biopsy. As in this case, we are doing a trucut biopsy of a thyroid lesion which was a lymphoma. When we do sampling from an FNA from a lymph node, we have an option of FNA or a trucut. So here's a small lymph node in the cervical area where we're doing a fine needle aspiration cytology, and these are two different nodes. Here we are using in-plane technique where we are seeing the entire needle, and here we are going out of plane where we are seeing only the tip of the needle. If the node is of an adequate size, it is better to do a trucut biopsy because the yield is much better. Here, for example, we are doing a trucut biopsy of a lymph node with a trucut needle, making sure that the needle does not hit the adjacent structures after firing it. So this is a way we do trucut biopsies of cervical lymph nodes. We have a very small area to work upon. So what we do is pass a small 16 gauge needle within the lymph node, and through this 16 gauge needle we pass an 18 gauge core biopsy needle and then cut. Now it's very important that when we do this obtain this core, we have to be parallel to the lymph nodes and go through the bulk of the lymph node and make sure that we don't go perpendicular and hit some solid area adjacent to the lymph node. Once you have mastered the technique, you can do biopsy of almost anything in the body which is visible to you on ultrasound, except maybe, of course, an aneurysm. So here is an example of a carcinoma of the esophagus where we are doing a trucut biopsy. In breast, again, we have an option of FNA versus trucut. But for all practical purposes, we try and do a trucut biopsy because the yield is much better, and we can always subject the tissue for hormonal analysis as well, or molecular diagnosis. When we do a breast biopsy, it is very important to go parallel to the chest wall. Here is a small lesion which is very close to the chest wall, and as you can see that it's a very cumbersome technique sometimes, but you can see that the needle is going parallel to the probe and it is going parallel to the chest wall as I fire, so that I'm not worried about pneumothorax. This is a very important thing to be done when we do a breast biopsy. As I said, most often we do a trucut, but sometimes if the lesion is too small and absolutely adherent to the chest wall, we might end up doing an FNA, as we can see here. Again, in the biopsy, in a breast, it is better to use a coaxial system because we can take multiple cores. So here we are again introducing a 16 gauge needle in a breast lesion, and through the 16 gauge needle we are introducing an 18 gauge trucut needle for a core biopsy. So that's the 16 gauge needle. The tip of the needle is in the lesion, and then through that we are passing an 18 gauge needle, and then we'll fire it once the needle is in position to get a core tissue, as we can see here. So that's the tip of the needle there, and that's the 18 gauge needle coming through that tip, and that's the needle being fired inside the lesion. So that's a very small lesion which is very close to the chest wall, but I'm going parallel to the chest wall and I'm using a trucut needle to obtain a core. This can be done very easily. Remember that when you are doing a guide wire localization, the technique differs because now we cannot go through the bulk of the plane we cannot go through a larger chunk of breast tissue. So we have to go as perpendicular as possible, because when the surgeon is going to resect the lesion along with the wire, he has to go perpendicular to the area where you have put your guide wire. So this is very important when you're doing a guide wire localization. When you are aspirating a complex cyst anywhere in the body, make sure that you take sufficient tissue from the walls of the cyst, and if there are any mural solid nodules, you take some tissue from that area also. For cytological diagnosis from cysts, one can use needles which have a longer length, but usually 22 gauge needle with a long needle or needle is good enough. So here we are doing a renal cyst aspiration, and as I go in, I am trying to go along the septae which are present in the renal cyst, and that's a liver cyst which is being aspirated. Very often if cysts recur, there is a tendency to put some agents which will basically sclerose that area, but one has to be very careful when choosing these agents. When we do a biopsy of the liver mass, especially if the mass is close to the capsule or it's a subcapsular lesion, then it is very important to go through a normal liver tissue and then enter the mass and then fire your gun, so that the risk of hemorrhage can be minimized. As I said earlier, that when we do a liver biopsy, it is very important to look at coagulation profile, because some of these patients may have a compromised liver functions with altered coagulation profile. When we do kidney biopsies for a native kidney, we generally like to go to the lower pole. Here again, it is very important that we go into the cortex of the kidney and not into the collecting system. When we do a liver or a kidney biopsy, we always infiltrate local anesthesia up to the capsule of the organ. As I said, anything which is seen well on ultrasound can be biopsied. Here, for example, we have a large lung tumor which was biopsied under ultrasound guidance, and this is a testicular tumor which is being biopsied, and we gave a complete block of the spermatic cord. So almost everything in the abdomen is amenable to ultrasound guided biopsies, whether it's a bowel mass, whether it's abdominal lymph nodes, whether it's an omentum with omental deposits, as we can see in these examples. For prostate, we again make sure that the area of where we are working is cleaned properly with betadine. We also make it a habit to inject some local lignocaine jelly within the rectum and keep it for some time before we start with the biopsy. Some people like to infiltrate lignocaine in the periprostatic area, but generally we do not do that. Again, we take proper aseptic precautions. Generally nowadays, we like to take 16 cores from the prostate. So we take 8 from each side, making sure that we take representative samples from all the peripheral zones on either side. So that's an example of a prostate biopsy being done. We generally start with the apex and come gradually towards the base, taking multiple cores at different levels. After prostate biopsy, patients could have pain. Look out, we ask them to report to us if they have hematuria. Infection is a known complication after prostate biopsy, so we cover them adequately with antibiotics, both injectable and oral. But when we give injectable antibiotics, it is important to look at the renal function of the kidney, renal function, and give antibiotics which are suitable. Some patients, of course, land up with retention. Amongst drainage procedure, very often we have to drain prostatic abscesses. So here we are putting a larger bore needle, 16 gauge or 18 gauge, into a prostatic abscess and then aspirating the entire pus out. Contraindications to needle biopsy. Well, if there is an uncorrectable coagulopathy, if there is a lack of safe biopsy route, if the patient is very uncooperative, or if you are not able to see the lesion, say because the patient is very obese or the lesion is retroperitoneal, then it is better to refer the patient for a CT scan. By far and large, percutaneous biopsies are very safe if performed correctly. and the incidence of serious complications is very rare. Intra-abdominal bleeding is extremely rare, but we have to look out for it. And again, damage to surrounding structures is again not common if your technique is proper, and infection is actually not seen in practice at all. Then we have drainage procedures. Typically nowadays we have drainage catheters which are loaded over a needle. So all we have to do is insert the entire set into the area of interest, remove the needle and keep behind the drainage catheter. If you're working in a small area and you don't want to leave behind the catheter, then we can very often use a JELCO as well. So that's a pleural tapping which is being done under ultrasound guidance. We like to do pleural taps under ultrasound guidance throughout, in the sense we like to keep the needle under observation till we finish the procedure. One has to have a reasonable distance between the pleura in inspiration to avoid any pneumothorax. So these are small pleural effusions which would be very difficult to aspirate without ultrasound guidance, and once we have mastered the technique, this becomes very easy. Very often when we do pleural taps, we'll end up with small pneumothorax, and most of them get absorbed and we don't have to worry about them. This patient had a coagulation problem and therefore after pleural tap developed a small hemothorax which was taken care of. That's an abscess which is being drained in the neck, and this was a tuberculous cold abscess. And very often to drain abscesses, we need to have larger needles like 16 gauge so that we can drain them adequately. That's a liver abscess being drained. Generally, if the liver abscess is small in size, we pass one needle, maybe 18 gauge or 16 gauge, and aspirate out the pus. But if the liver abscess is large, say above 8 centimeters or so, or if it has refill, then we like to keep behind a pigtail until the entire abscess is healed, as we can see here. That's a nephrostomy being done for a patient who was suspected to have pus in the kidney. So that's the local anesthesia being given, and as you can see, we are going right up to the capsule of the kidney. The needle is touching the capsule of the kidney. That is what you should do when we do liver biopsies or do any procedures in relation to the kidney or the liver. Next, we are passing a catheter, and you can see the tip of the needle entering the lower calyx within the collecting system. So once we are sure that the needle tip is well within the collecting system, we can confirm by just removing the inner needle. Then we remove the complete needle and aspirate, and there we can see the pus coming from the kidney. This is a procedure which can be done very easily in the OPD or wherever is your department. Very often after transplant we get fluid collections, and they can be aspirated under ultrasound guidance, and this procedure is very often very rewarding because altered renal functions very often come back to normal. When it comes to ovarian cysts, it all depends. The approach depends upon the visibility of the ovarian cyst. If the cyst is very easily seen transabdominally, we might do it transabdominally. But if it is seen better transvaginally, then it is better to do with a transvaginal scan with a guide which is attached to the probe. RFA is a different talk altogether, but this can be again very easily done under ultrasound guidance. Similarly, musculoskeletal intervention is a different talk altogether, but we can do a lot of things. We can aspirate fluids, we can remove calcium, we can just tease a cord, a tendon, and we can inject steroids, or we can also inject PRP to heal a tendon or a tendon insertion. Again, vascular access nowadays is best done under ultrasound guidance in an intensive care setup. We have newer technologies which help us in intervention. For example, we have an X-matrix probe, and with this probe, we can see the needle in two planes so that we are sure that we are within the lesion and not outside the lesion. We also have volumetric ultrasound, and you can now see the needle in multiple planes, so that again the accuracy can be very, very high. These are two examples where we are doing an intervention with a volumetric probe, and you can see the needle much better. Very often, if the lesion is not well seen on grayscale, one can inject contrast. And typically, if you are dealing with the liver metastatic deposits in the late phase, the contrast washes out and these lesions stand out as black holes within the liver. Sometimes we use elastography to find out from which area to biopsy. For example, in the prostate, we are using elastography, and wherever there is a hard area, those areas we'll biopsy under ultrasound guidance. Then, of course, we have fusion technology, where we can see the lesion on CT or MR, then go back to the ultrasound machine, because ultrasound has a big advantage of being real time, fuse the CT MR pictures in the ultrasound pictures, and then do the procedure accurately. So again, to summarize, any lesion that is well visualized on a sonogram is amenable to ultrasound guided intervention. Ultrasound is a real-time technique, and it shows the tip of the needle at all times during procedure, and therefore it is extremely safe and reliable. Thank you so much.